Ma'am, we are on live, ma'am, and we are starting the session, ma'am. Ma'am, we are starting, ma'am. Yes, ma'am. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's session is PCOS and ovulation induction. I welcome all the participants and I request them to post their queries in the comment box so that we can have a short Q&A session at the end of this presentation. And before going to the session, I would like to take 1 minute of your time for explaining our Shield Connect web page. So this is our Shield Connect web page, ma'am. So you can just type it as shieldconnect.in and you can log in into our page. You can find various information which is related to women's health is available in our web page, ma'am. So we have a separate page for blogs. Most of our experts are writing these blogs, and all these blogs are available in our web page for the audience to go through our blogs, ma'am. And we also have a separate page for webinars. So all our webinars are conducted through our Shield Connect web page, and you can find the details of upcoming webinars, and you can find the recorded version of all the past webinars which is available in our web page, ma'am. And we also have a separate page for awareness program. You can just see PCOS awareness here. So you can find short videos of doctors explaining about PCOS, which is available in our web page, and it's available in all regional languages like Tamil, Hindi, Telugu, Malayalam, and various regional languages of India. And we also have a separate page for our leaders, ma'am. So we have more than 400 doctors who are supporting our web page through their webinars and through their scientific content, ma'am. Ma'am, I request you to share 1 or 2 blogs which you feel that you can share with your colleagues, can be posted in our web page, ma'am. So it will be useful for the participants who are going through our web page, ma'am. So, ma'am, now I take my time to introduce the invited speaker for the day, Dr. Kalpana Singh, ma'am. Madam has completed her MBBS and MD. Madam is currently the additional professor and head Department of Reproductive Medicine, Indira Gandhi Institute of Medical Science, Patna. Madam is also the founder, Joint Secretary, Indian Fertility Society, Bihar chapter. With this short introduction, I welcome you, ma'am. I'm handing the session to you for further proceedings, ma'am. Thank you.
Thank you very much for your kind introduction and for the opportunity to speak over here. I shall be speaking. Yeah, today I'm going to speak on ovulation induction in PCOS patients. I think the last slide has come. Just. Yeah. So today I'm going to speak on PCOS and ovulation induction in such patients. Am I audible? It's okay?
Yes, ma'am. Yes, ma'am.
So we all know that polycystic ovarian syndrome is a complex multifactorial endocrine disease characterized by oligomenorrhea, hyperandrogenism, polycystic ovary morphology as seen in the ultrasound. Diagnosis of PCOS are frequently made for the first time in infertility clinic during evaluation for infertility. The prevalence of PCOS is between 8.5 to 20% depending on the criteria used for the identification of the condition. We shall not be going in the detail of the diagnostic criteria. So proceeding further, the epidemiology. It is one of the most common endocrine disorders affecting women of reproductive age group. It is seen in 8 to 11% of reproductive age group women. It is most common cause of anovulatory infertility in women. Anovulatory infertility is seen in 70 to 80% of PCOS patients. Indians have amongst the highest prevalence rate in the world, 41% in the reproductive age group. Pathophysiology, we all know that there is insulin resistance and LH levels are high, FSH levels are low. We shall not be going in detail of the pathophysiology. Basically, what happens in PCOS, we all know that insulin is primarily responsible for controlling LH, and also it controls the androgen production. But in cases of PCOS, there is obesity or insulin resistance is there. So women with PCOS have decreased sensitivity to circulating insulin irrespective of weight. We also find lean PCOS. So weight is not the only criteria for insulin resistance. They have inbuilt insulin resistance, and thus suggesting that insulin insensitivity is intrinsic to PCOS. Inositol deficiency drives PCOD. This insulin resistance seems to be driven by deficiency of myo-inositol and D-chiroinositol. Myo-inositol deficiency triggers disrupted insulin signaling, and insulin dysfunction disrupts the FSH-LH pathway and hyperandrogenism. So this is one of the way of explaining PCOS. We all know the clinical features of PCOS. One of them is gynecological. That is, most of the time they have irregular, infrequent menstruation. Menstrual cycle is usually after 45 or 60 days, but flow is most of the time normal, and they have difficulty in conceiving. Then there are metabolic components if she happens to be case of syndrome. So we can find that there is insulin resistance. Obesity is most of the time there, and there is increased chance of type 2 diabetes mellitus, and acanthosis nigricans can also be seen. Then we can have androgenic features as well in the form of alopecia, hirsutism, acne, etc. Now coming to anovulatory infertility in PCOS. Infertility is distressing medical and psychosocial, and it affects the 1/4 of all the couples. Majority of anovulatory problem in females as a cause of infertility is due to polycystic ovarian syndrome. So we all know that it is because of infertility is mostly contributed by polycystic ovarian syndrome. PCOS increase the risk of other adverse conditions such as metabolic syndrome, cardiovascular disease, type 2 diabetes mellitus, and endometrial cancer as well, along with infertility. So this is a very important problem and should be addressed at right time. The treatment of anovulatory infertility in PCOS is as enigmatic as the disease itself. So how to increase the chance of conception in infertile PCOS woman? Ovulation induction, just before starting, I'll be just defining the ovulation induction. It is a fertility treatment that uses medication to cause or regulate ovulation so as to increase the chances of pregnancy. So what can we do to increase the pregnancy rate in cases of PCOS patient? If she is obese, then lifestyle modification intervention is of most importance, because the moment she reduces her weight by more than 5%, insulin resistance decreases dramatically and ovulation resumes. Then we have got certain pharmacological agents which I shall be discussing in detail for ovulation induction, and in resistant cases we have option of doing surgery in the form of laparoscopic ovarian drilling. So first line drug is Clomiphene citrate. It is used in cases of anovulatory PCOS. Then we have it is a selective estrogen receptor modulator, and we also use Letrozole, which is a 3rd generation aromatase inhibitor. And we have got Metformin, which is an oral hypoglycemic agent. It works as insulin sensitizer and it reduces insulin resistance, which is a feature of PCOS. Then we have got Gonadotrophins and Myo-inositol, and Myo-inositol is a type of dietary supplement. So in evidence-based practice, as suggested by Ishray, this is the algorithm, assessment and treatment of infertility in cases of PCOS patients. So first line therapy is non-pharmacological management of infertility, that is lifestyle intervention. Here we suggest the patient to reduce carbohydrate intake, increase the physical activity, and reduce weight, at least 5%, at least 5%. Then we have got first line pharmacological treatment for infertility. So nowadays letrozole is considered as first line therapy. Clomiphene citrate is also there. This is also first line therapy. Then we can use clomiphene citrate along with metformin, metformin alone, and gonadotrophins are all considered in the first line pharmacological therapy for PCOS patients. Then in second line pharmacological or surgical management, we have got in the form of drugs, we have got gonadotrophins, and if indicated, then we can go for laparoscopic ovarian drilling. And in third line is IVF. So few words about clomiphene citrate. It is most widely used treatment for fertility enhancement for last 40 years. So experience is widest with the clomiphene citrate. Clomiphene citrate become very popular for induction of ovulation because of its ease of administration and minimal side effects, and it is widely available, easily available. It is a non-steroidal derivative, acts as a selective estrogen receptor modulator like tamoxifen. Clomiphene isomers have mixed estrogenic and anti-estrogenic effects that vary among species. So N-clomiphene is the more potent isomer with greater anti-estrogenic activity and is the one primarily responsible for inducing follicular development. Clomiphene citrate binds to estrogen receptors and exerts its major effect on the hypothalamus, pituitary, ovary, and the uterus. The primary site of clomiphene action is the hypothalamus, where it appears to bind to and deplete hypothalamic estrogen receptor, thereby blocking the negative feedback of the circulating endogenous estradiol, and this results in increase in hypothalamus GnRH releasing hormone pulse frequency and increased serum concentration of FSH and LH. And in vitro data suggests that clomiphene citrate also has a pituitary site of action, where it causes an increase in gonadotrophin response to GnRH. So there are various modalities of action of clomiphene citrate. This therapy is a clomiphene therapy for ovulation induction is typically started on second or third day of menstrual cycle, either following spontaneous or induced bleeding. The initial dose is 50 milligram daily for 5 days. Starting with a higher dose does not result in higher pregnancy rates. But if ovulation does not occur in the first cycle treatment, then the dose is increased to 100 milligram. We can further increase it to 150 milligram. 100 milligram is the maximum dose approved by US FDA. But sometimes we do use 150 milligram as well. American Society of Reproductive Medicine suggests that more than 100 milligram add little to clinical pregnancy rates. Once ovulation is achieved, then the same dose should be continued for 4 to 6 cycles. We should not go beyond 6 cycles if pregnancy is not achieved. LH surge occurs from 5 to 12 days after the last day of clomiphene administration. Hence, the couple is advised to have intercourse every other day for 1 week, beginning 5 days after the last day of medication, or we can do a follicular study and we can do IUI. IUI is a better way of dealing in these patients because timed intercourse has got lesser pregnancy rate as compared to ovulation induction along with IUI. So pregnancy rates are low after 6 cycles of treatment, and that 12 or more cycles may increase the risk of ovarian neoplasm. So after 6 cycles, we should re-evaluate the patient and replan the treatment. American College of Obstetrician and Gynecologists suggests that clomiphene citrate can be limited to fewer than 12 cycles and that the number of gonadotrophin cycles be minimized. Change in therapy for women who do not conceive after 3 to 6 cycles of clomiphene citrate cycles. So we should not go on giving clomiphene for 12 cycles. No, we have to review our treatment and see where is the cause, why she is not conceiving. Then there are certain other ways of giving clomiphene citrate in PCOS patients. That is luteal phase start or ultra short protocol. So what do we do in luteal phase start? It is usually used in patients who are amenorrheic PCOS patients. It can be started immediately after the last dose of medroxyprogesterone acetate. So we gave medroxyprogesterone acetate for 5 days, 10 milligram 5 days, and we don't wait for withdrawal bleeding. Immediately we started. So early initiation of clomiphene citrate before withdrawal bleeding or during the last days of luteal phase can achieve a better ovulatory response. So a study was done by Padway et al. And it was found that in 227 cycles in 110 patients, they gave 100 milligram of medroxyprogesterone acetate in the luteal phase. After completing the medroxyprogesterone acetate, next day the patient started taking clomiphene citrate, and in the other group, clomiphene citrate was given from the day 3 of menstrual cycle. This was again done in 211 cycles in 102 patients. We found that ovulation happened a bit more in early start group. Endometrial thickness was also better, and pregnancy rates were also better. Though this was not statistically significant, but at least equal or better pregnancy rates were achieved. Number of follicles were significantly higher in the luteal phase start group. Endometrial thickness was also better. This I'm talking about the similar strategy, but done by another person, Samia Mohammed et al. And he found that the number of follicles, endometrial thickness, and serum estradiol and pregnancy rates were better in the patients in whom we started clomiphene citrate in the luteal phase. Then we have got another method of giving clomiphene citrate. This is called ultra short term. Here clomiphene citrate 50 or 100 milligram is given from 3rd day of menstrual cycle, and it is given just for 2 days. And it is usually given in patients in whom we suspect that she is a high responder, she is at risk for ovarian hyperstimulation syndrome, or multifollicular development can happen. So in these patients, we just give for very short duration, that is just for 2 days. And here it was found that these patients had monofollicular, almost monofollicular or 2 follicular development, and the duration of follicular phase was also average 12 days. Ovulation rate was found to be 80%. Pregnancy rates were also quite good. So in hyper responsive patients, if we plan IUI, then it is a good choice. Now coming to ovulation induction with letrozole, this is a 3rd generation aromatase inhibitor. In inducing ovulation, letrozole acts primarily in the ovary, where it antagonizes the effect of enzyme 5-alpha reductase in the production of estrogen in the ovary. It effects to inhibit the conversion of testosterone and androstenedione to estradiol and estrone. It also blocks the conversion of androgen to estrogens in the peripheral fat cells and suppresses local estrogen production in the brain. The reduced levels of estrogen releases the hypothalamus from the negative feedback effect of estrogen and causes increased production of FSH for the folliculogenesis and ovulation. So in absence of anti-estrogenic effect that are observed in CC at the level of endometrium, which perhaps is responsible for its higher pregnancy rate and live birth rate. So it doesn't have anti-estrogenic effect, which is usually observed in clomiphene citrate cycles. So this we have already discussed. Now coming to the ways of therapy with letrozole. So standard therapy, we all know, either we give 2.5 milligram or 5 milligram. Sometimes it can be given up to 7.5 milligram for 5 days. Typically it is started on 2nd day, but it can be started on 3rd or 4th day as well. There are certain newer protocols. One is extended protocols. Here we give letrozole 2.5 milligram per day from day 1 to day 9. Then there is another protocol. In this protocol, we give single high dose of letrozole. So one dose of letrozole, 20 milligram, is given on 3rd day of menstrual cycle, and that's it. Then we have got step protocol. In this protocol has been tried with both clomiphene citrate and letrozole. Though the time to ovulation is shorter, pregnancy rates are not higher. Then we have got extended protocol. Here we give letrozole from day 3 to day 12, that is for 10 days. And the advantage is that this is beneficial in CC resistant PCOS patients. And we have got ovulation rates are good, 66 versus 61%, and pregnancy rates are also good. So coming to the letrozole step-up protocol, in this study group included 9 patients, 11 cycles, who received letrozole in a step-up protocol consisting of 1, 2, 3, and 4 tablets of letrozole, 2.5 milligram daily on menstrual cycle days 2, 3, 4, and 5 respectively. The step-up protocol was associated with multifollicular ovarian development in 11 cycles with a mean of 2.2 to 1.5 SD mature follicles per cycle, similar to CC. A tendency for higher clinical pregnancy rate per treatment cycle was compared with CC, was also observed with letrozole step-up protocol. So now coming to another study here, letrozole and clomiphene citrate with gonadotrophins are evaluated in IUI cycle. This is a randomized controlled trial, and this was done by Corali et al. And published in 2017. 180 women randomly allocated to clomiphene citrate or letrozole along with HMG. So in group 1, 100 milligram of CC along with HMG was given. HMG was added on day 6, 7, 8 of the cycle. And in group 2, 5 milligram of letrozole along with HMG. HMG again for similar days was added, and the results were that the number of mature follicles, cycle cancellation, and abortion rates were same in both the groups. Endometrial thickness was higher at the time of HMG administration in letrozole group. Chemical and clinical pregnancy rates were much higher in letrozole group, and ovarian hyperstimulation was significantly higher in CC group. Now coming to the role of metformin for ovulation induction in PCOS patient, should we add metformin to letrozole or CC? The role of metformin for ovulation induction in infertile patients with polycystic ovarian syndrome. Metformin in combination with CC improves ovulation and clinical pregnancy rates, but does not improve live birth rates compared with CC alone in women with PCOS. There is a fair evidence from one randomized controlled trial that pre-treatment with metformin for at least 3 months, followed by addition of another ovulation-inducing agent, increases live birth. So this is a better way of treating the patients. Insufficient evidence to compare metformin plus CC to aromatase inhibitor alone or metformin plus aromatase inhibitor for ovulation induction. So we don't have much data on these to compare or to comment. Fair evidence that metformin used while attempting pregnancy and stopped at the initiation of pregnancy does not affect the miscarriage rate. This is as per the Fertility Sterility 2017 ASRM. So clomiphene citrate remains preferable to metformin alone for ovulation induction in obese women with PCOS, and improved pregnancy rate on ovulation rate with metformin and CC versus clomiphene citrate alone, but no increase in the live birth rate. There is no evidence of increased miscarriages, but gastrointestinal side effects are more likely with metformin alone or with the combined therapy. This is according to the Cochrane 2017 data analysis. So here we have a study done by Vijeka A, and it was published in 2016. So 60 moderately obese patients with PCOS, 30 CC plus metformin, and in 29 patients, letrozole with metformin were given, and stimulation was carried out, and these are the results. So letrozole with metformin is better than clomiphene citrate with metformin in moderately obese patients with polycystic ovarian syndrome who are resistant to stimulation with CC. But this is small study, yet it has not come in the recommendation. So we all know that clomiphene and metformin for anovulatory infertility in obese patients is preferred, and in obese patient who has got BMI more than 30, combination of clomiphene and metformin rather than metformin alone. So clomiphene along with metformin is standard for obese patients, and pre-treatment with metformin gives better results, but certain studies are suggesting that letrozole along with clomiphene is also good, yet more studies are needed for a recommendation. So what if CC resistance is found in PCOS patients? So if the woman is obese, then weight reduction is the first thing which is to be done, and if she is not obese, then metformin along with CC can be attempted for 3 to 6 cycles. Third generation letrozole or can also be attempted, or in a resistant patient we can go for gonadotrophin only stimulation, or letrozole laparoscopic ovarian breeding can be done, and if it all fails, then IVF is the answer. Gonadotrophin is considered second line treatment for ovulation induction in anovulatory infertility. It can be used in clomiphene resistant patients. Gonadotrophins plus metformin in CC resistant patients gives good results. Low dose FSH stimulation is indicated in women who fail to ovulate upon treatment with CC or letrozole. Treatment requires experience with gonadotrophin stimulation, careful follow-up, and possibility of converting to IVF in cases of multifollicular development. If follicle development occurs, the same dose is maintained until the follicle size reaches 18 to 20 mm, followed by induction of final maturation with HCG. In PCOS patient, chronic low dose regime is preferred because it minimizes the chances of OHSS. So here the starting dose is usually 37.5 IU, and the duration of the starting dose is 14 days. Weekly dose increment of 37.5 IU is done until ovulation, followed by IU. Overall, ovulation induction with IUI results in singleton pregnancy, singleton live birth with marked reduction of OHS. Few words about myo-inositol. So myo-inositol promotes glucose intake and FSH activity. Then D-chiro-inositol causes a reduction in insulin-stimulated androgen synthesis in the ovary. Both of these effects may positively affect ovarian function in PCOS patient. A number of studies found that myo-inositol treatment significantly increased the likelihood of spontaneous ovulation compared with placebo. Doses used are for myo-inositol 2 gram and for chiro-inositol 0.6 gram, both taken twice daily, and treatment duration is reported to be between 2 to 6 months. Adverse effects seem to be negligible and limited to mild abdominal discomfort. So myo-inositol, it corrects the altered LH-FSH ratio by regulating GnRH pulsatile release. It improves insulin sensitivity by acting as a secondary messenger for insulin action in the peripheral tissue, brings down plasma level of insulin, and improves ovulation and oocyte quality by acting as a secondary messenger of FSH. So International Society says, American Society for Reproductive Medicine in 2012. Myo-inositol can be evaluated as the primary method for ovulation induction in PCOS women, and myo-inositol treatment should be routinely introduced in IVF protocol. So we have got here a clinical trial which was published in Gynec-Endocrinology 2015, and ovulation induction with myo-inositol alone and in combination with clomiphene citrate in polycystic ovarian syndrome patients with insulin resistance. And result was that myo-inositol treatment ameliorates insulin resistance and body weight and improves ovarian activity in PCOS patients. Now, few words about laparoscopic ovarian drilling. Laparoscopic ovarian diathermy or drilling is a further development of the wedge resection procedure and was introduced in early 1980s. Initially, because in PCOS patient the ovarian volume was more, so when these much development were not there, then wedge resection used to improve the ovulation and pregnancy rates. But when we have got laparoscopy and ovarian drilling is possible by cautery diathermy, then this is now being done, and wedge resection is nowadays obsolete procedure. A Cochrane review concluded that LOD was as effective as other treatment option in CC-resistant patients, and long-term follow-up studies have shown that the method is cost-effective compared with the other ovulation induction procedures and has a low risk of multiple pregnancies. Although the effect of ovarian surgery for PCOS is not fully understood, a decrease in the level of testosterone, androstenedione, estradiol, and LH has been shown, while FSH in some cases increases, possibly due to a reduced negative feedback from the estradiol. So, laparoscopic ovarian surgery could be second-line therapy for women with PCOS patient who are clomiphene resistant. With anovulatory infertility, laparoscopic ovarian surgery could potentially be offered as first-line treatment if laparoscopy is indicated for other reasons in women with PCOS with anovulatory infertility and no other infertility factors. But I will suggest that this should not be usually attempted, because premature attempt, sometimes premature ovarian failure can also happen. So ideally, it should be considered as a second-line therapy in cases where CC resistance is seen. So risk should be explained to all women with PCOS considering laparoscopic ovarian surgery. When laparoscopic ovarian surgery is to be recommended, the following should be considered: comparative cost, expertise required for the use of ovulation induction, intraoperative and postoperative risk are higher in women who are overweight and obese. There may be small risk of lower ovarian reserve or loss of ovarian function, and periadnexal adhesions may form. And if nothing works, then recombinant, then IVF may be recommended. So in these patients, recombinant LH may not be used routinely with FSH. GnRH antagonist protocol is preferred over agonist protocol because reduced duration of stimulation is there, decreased dose and cost, and decreased OHS risk is there. In agonist protocol, no fresh transfer is planned, and trigger is usually given by GnRH agonist, and freeze all embryos. Consider elective freeze of all embryos, because in PCOS patient we usually prefer segmented IVF. So in one cycle we do stimulation preferably by GnRH antagonist protocol, and in another cycle we go for embryo transfer. This minimizes the risk of OHSs in PCOS patients. So we have discussed most of the treatment modalities. So thank you all for your patience here.
Thank you, ma'am. Thank you very much for that detailed presentation, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I will read it for you, ma'am.
If there is any query?
Yeah, ma'am. There is one question, ma'am. Whether metformin can be combined along with CC in obese patient, ma'am.
Metformin alone also helps, but if we use metformin along with CC, then it gives better result. So if you want to use metformin alone, then ideal would be pre-treatment with metformin for 3 months, and then use clomiphene citrate along with metformin. So this therapy also increases the live birth rate and pregnancy rates.
Okay, ma'am. One more question is there. How many cycles of letrozole can be tried in this couples, ma'am?
Ideally, not more than 6 cycles, whether it is CC or letrozole. But after 3 cycles, if you are failing successively in 3 cycles and ovulation is happening, ovulation is being documented by ultrasound, then you should review where is the problem. If there is some associated other pathology, like in these patients, sometimes endometrial hyperplasia can be there because of anovulation, unopposed estrogen. So you must review. It's not that we have to do 6 cycle in continuity and then only, because every ovulation induction increases the chronological age of the ovary. It further increases the risk of ovarian malignancy as well, though the risks are less. But you should not use clomiphene citrate or letrozole without any regulation or in rampant use. It should be used under supervision and when indicated.
What will be the role of adjuvants like N-acetylcysteine and other vitamin D3? Whether it will be helpful in this treating fertility?
Yeah. Vitamin 3 also helps in reducing insulin resistance, one, and it also helps in achieving ovulation. So other than this, vitamin D has got anti-inflammatory effect on the body. It works in almost all the system. So if we have optimum level of vitamin D, so immunity is better, inflammation is less, ovulation happens, insulin resistance is less. So that way chances of achieving pregnancy improves. It becomes better. So it changes the environment of the body and makes it more pregnancy friendly. So that way we should always supplement these patients with vitamin D, because in India vitamin D deficiency is like epidemic, pandemic. It is very much common. So either we can go for supplementation or we can get the vitamin D level, and depending on the level we should supplement.
Yes, ma'am. I have one last question, ma'am. When we are looking at the patient journey, when they are looking for infertility treatment, they are not meeting the experts at the beginning, and they are meeting the general physicians, and they are coming to the fertility center, ma'am. So, if a PCOS woman who is having more cyst, and if a general practitioner is giving this CC, clomiphene citrate in that patient, whether it will have any impact on that patient, ma'am? Whether the cyst will be becoming more and more big. Is there any such cases, ma'am?
If cyst is big, more than 3 centimeter, then clomiphene citrate ideally should not be used. We should address the cyst first, because all the FSH and all the endocrinological changes may increase the size of cyst. So ideally cyst should be addressed first, and then we should go for the stimulation. So before the stimulation, we should have a ultrasound report of the patient, what is the status. And I would also like to suggest that unregulated and without doing any follicular tracking, we should avoid giving any ovulation inducing agents. We should always give CC or letrozole and monitor, plus try to do IUI, timed IUI, rather than leave the patient for intercourse, because the pregnancy rates are less. So this frustrates also this is frustrating to the patient as well as to the treating physician. So whenever feasible, we should go for ovulation induction and IUI, which has got better pregnancy rate than only ovulation induction.
Thank you, ma'am. Thank you very much for your time and wonderful presentation, ma'am. Ma'am, I don't find. Yeah, ma'am. We have one more question, ma'am. Like metformin is only for obese PCOS patient. Yeah, ma'am. That's the question, ma'am. Whether metformin is only for the obese PCOS patient.
Metformin basically is for insulin resistance. So insulin resistance is not necessarily limited only to obese patients. Sometimes normal BMI patients may also have insulin resistance. So you have to see for the features of insulin resistance. So there are two ways. One is the clinical sign symptoms of insulin resistance that you can see, or you get a serum insulin level done along with the fasting blood sugar. That will tell you if insulin levels are high, then go for metformin. And pre-treatment is ideal. If pre-treatment time is not there, pre-treatment you cannot go, then clomiphene citrate along with metformin also gives good result.
Fine, ma'am. Ma'am, there is no other questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
Pardon?
Ma'am, there is no questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
Yeah.
Yeah, ma'am. Thank you. Thank you very much for your time, ma'am. Thank you very much for the audience for their active participation, ma'am. On behalf of Shield Healthcare, I would like to thank all the participants and our Shield team for making this webinar possible, ma'am. Ma'am, we are looking for many more webinars with you, ma'am. So I request you to give more webinars for our Shield Connect web page, ma'am. And if there is any blogs that you need to share, you just send us the mail, ma'am. We will be working on it and we'll be posting it on our web page, ma'am. Thank you, ma'am. Thank you very much.
Thank you, Dr. Stalin, very much for providing the opportunity, and thank you, Shield Pharma, for organizing this. Thank you very much.
Thank you, ma'am. Ma'am, I'm ending the session.